Hey everyone, welcome back. If you just watched part 1, awesome. Let's continue from where we left off. If you're coming straight into part 2, no problem. I'll give you a quick context so you don't get lost. Back in part 1, we talked about the foundations of the emergency approach to the critically ill patient. We saw how emergency care is completely different from routine care. We understood the concept of the platinum minute that is specific to veterinary medicine, the crucial importance of having a trained and synchronized team, and all the structural equipment requirements that an emergency room needs to have. Now, in this second part, this is where things get really practical. We're going to dive deep into what you really need to do when that critically ill patient arrives in front of you. First, I'm going to teach the complete severity-based triage system, how you categorize patients from I to V according to the risk of death, and how this determines the order of care when you have multiple patients simultaneously. Then we'll detail the entire ABC protocol, how to ensure a patent airway with all the available techniques, how to establish good breathing and ventilation, and most importantly, how to assess circulation through all the parameters that really matter. I'll present the ABORDAGEM acronym for the secondary assessment, which is a super efficient method so you don't forget any system during the exam. And we'll close talking about continuous monitoring and all the nursing care that makes a difference in the patient's recovery. So get ready, because now comes the part you'll apply directly in practice. Let's go.
Let's now talk about triage, which is the first critical moment of care. To triage in the emergency room means to separate patients by order of severity. It is the first moment of contact with the sick patient, when we must decide between one patient and another, anticipating and identifying the one who will die first. This decision can be very difficult, but it is necessary. If you have two patients arriving simultaneously, which one do you treat first? The one that will die first if not treated immediately.
Normally, the first person to come into contact with the owner is the reception staff, and that person must be trained to provide efficient service from the first contact on the phone. The trained receptionist must be able to direct the history by asking key questions, provide information to the owner about the correct way to transport the traumatized animal, and give guidance on the first aid that can be offered to the patient until arrival at the clinic. When possible, this more technical information must be given by the on-call clinician directly on the phone. The receptionist must also be able to provide information to the on-call team about the patient who is arriving so that the team prepares. For example, an unconscious dog hit by a car with active bleeding is arriving. This information allows the team to prepare the room, separate materials, and be ready when the patient arrives. Triage must be performed focusing on the patient's risk of death, establishing the sequence of care. And we must remember that a patient can change their state at any moment during the wait or during the care itself, making this triage system flexible, especially in the first hour after the initial care. There is a standardized triage classification that you need to know. Let's go through the 4 categories, from the most serious to the least serious, with the maximum care time of each one. Category I, emergency, immediate care. These patients must be treated in a maximum of 1 minute, if possible in seconds. Who are these patients? They are those in cardiorespiratory arrest, with complete obstruction of the airway, and all unconscious patients. Usually, severe hypotension, absence of audible heart sounds, profound hypothermia, and mydriasis, which is pupil dilation, are the signs that characterize this group of patients. These patients don't wait. You drop everything and go. Category 2, very serious, critical. Action must be taken within 5 to 10 minutes maximum. These are patients with severe respiratory insufficiency, usually with a still stable hemodynamic picture, but who will go into total arrest if not treated quickly. All dyspneic patients with evident respiratory difficulty, with difficulty maintaining a patent airway, and with significant ventilatory changes are in this group. Patients in classic shock with pale mucous membranes, prolonged capillary refill time, cold extremities, weak pulse are also part of this group. Category 3, serious, urgent. All patients with multiple injuries but who maintain a patent airway and adequate ventilation.
Care must occur within a maximum of 2 to 3 hours. Open fractures, open wounds, or extensive burns. Penetrating foreign body in the abdomen but without active hemorrhage. Or trauma without apparent signs of shock at the moment. In addition to states of altered consciousness such as seizures, are the cases included in this class. Cryptic shock, the one that has no obvious signs but is setting in, and initial hemodynamic decompensation are also classified in this group.
Category 4. Relative urgency. Action must occur within 24 hours. Most traumatized patients do not fit into this category, but some only become evident after the owner reports persistence of clinical symptoms. Persistent anorexia, vomiting, lameness without other signs of severe trauma, bad smell for myesis, infected wound or abscesses, and apathy without other signs are some of the cases that fall here. The clinical history in the emergency room must be brief, within 1 minute maximum, objective, and performed together with the initial emergency physical examination. When applicable, the anamnesis can be anticipated by telephone service, as we mentioned. What questions are essential in this 1-minute anamnesis? What happened? When did it happen? Is the animal conscious? Is it breathing? Is there visible bleeding? This basic information already directs the initial approach a lot. Treatment always begins before diagnosis, since most of the time there is no time to establish it. This is fundamental for you to understand. You don't wait to confirm the diagnosis to start treating. You treat what you are seeing, what is immediately threatening life. Let's go now to the ABC protocol, which is absolutely essential and saves lives daily. A worldwide accepted algorithm in the care of the critically ill patient was adapted to the veterinary reality and today is widely disseminated and accepted. It is known as ABC and involves establishing airway patency, good breathing/ventilation, and circulation, respectively. The algorithm in English means airway, breathing, circulation. The use of algorithms in emergency approaches is consecrated and can significantly increase survival obtained in the emergency room. There is a study that observed an improvement of more than 20% in the survival rate when standardized protocols were installed in the emergency service. That's huge.
Currently, 3 exceptions to the ABC protocol are accepted: large caliber hemorrhages, ventricular fibrillation, and cardiopulmonary resuscitations performed by only one resuscitator when you are alone. In these specific cases, you may need to start with circulation before the airway. Let's detail each step of the ABC, starting with A, which is airway, patent airway. The first thing you have to ensure is that there is a patent and free airway, with continuous ventilation occurring. How do you verify this? You observe if the chest is moving, if there is airflow through the nostrils, if you can hear breathing. If the airway is not patent, you need to act immediately. First step, stabilize the cervical spine. Why? Because if there is trauma, there may be a cervical spine fracture, and abrupt movements can worsen the spinal cord injury. With the spine stabilized, extend the patient's tongue out of the mouth by pulling it gently. Perform suction of the oral cavity to remove blood, vomit, secretions, or foreign bodies that may be obstructing. If this is not enough to establish a patent airway, you need to move on to more invasive methods. The next option is orotracheal intubation, which is passing an endotracheal tube through the mouth into the trachea. If orotracheal intubation is not possible, for example due to severe facial trauma, mandible fracture, glottic edema, you can try retrograde intubation, where you make a small incision in the trachea and pass the tube from the bottom up. If even that doesn't work, you move on to cricothyroidotomy, which is making an emergency access through the cricothyroid membrane to ventilate the patient, or tracheostomy, which is a more formal surgical access to the trachea, or even cricoid puncture, which is literally puncturing the cricothyroid membrane with a large caliber needle to allow air entry while you prepare something definitive. Let's now go to B, which is good breathing. Establishing a patent airway is not enough. You need to establish good ventilation and oxygenation. Air needs to be entering and leaving the lungs effectively and needs to be being oxygenated. How do you assess this? You observe the amplitude of respiratory movements, the respiratory rate, the bilateral pulmonary auscultation, the color of the mucous membranes, and ideally the oxygen saturation by oximetry. If necessary to obtain adequate chest expansion, you may need to perform thoracocentesis, which is the puncture of the pleural space to remove air or fluid, or placement of a chest tube, which is a drain that stays in the pleural space, draining continuously. These situations occur in cases of pneumothorax, where there is air accumulated in the pleural space, preventing lung expansion, or hemothorax, where there is accumulated blood, or pleural effusion from any other cause. And you must be trained to use all available means of oxygenation. What are these means? Face mask, nasal cannula, nasal catheter, oxygen tent, biflow, which is placing the oxygen hose near the nostrils, or assisted ventilation with ambu bag when the patient is not ventilating adequately on their own.
And now let's go to C, which is circulation. And this is a very important and detailed part. You need to verify if there is adequate perfusion, and for this, you need to establish vascular access to be able to administer fluids and medications.
The synchrony of arterial pulse and heart rate must be assessed. You auscultate the heart and count the heart rate and simultaneously palpate the femoral pulse. Each heartbeat must generate a palpable pulse. If there is a pulse deficit, it indicates that not all beats are generating adequate output.
And then you assess the circulatory parameters systematically: central, peripheral, and peripheral environmental temperature deltas, capillary refill time, which must be less than 2 seconds, jugular emptying time, color of mucous membranes, which must be pink, abdominal auscultation, arterial pressure, which must be above 90 millimeters of mercury, ideally, central venous pressure when possible, and oximetry, which must be above 95%.
And very important, resuscitation based on the lactate curve and on goal attainment is the most recommended currently. Lactate is a marker of tissue hypoperfusion. Normal is below 2.5 millimoles per liter. You establish specific goals and titrate your resuscitation to achieve them.
At this point, it may be necessary to perform a fluid challenge, a fluid bolus to assess volemic response, or abdominal compression to mobilize blood from the splanchnic territory. After the primary approach is complete, you do a more complete physical examination using the ABORDAGEM acronym, which in English we adapt to the same systematic check.
A. Airway. Reconfirm patency. B. Breathing. Reassess ventilation. O. Oxygenation and ophthalmology. Check saturation and pupillary reflexes. R. Heart rhythm and respiration. Complete cardiac and respiratory auscultation.
D. Urinary output and pain. Check urine production and assess pain. A. Abdomen. Careful abdominal palpation. G. Gastrointestinal. Check vomiting, diarrhea, peristalsis. E. Extremities and neurological state. Examine limbs and consciousness. M. Continuous monitoring. Ensure recording of all parameters. This sequence must be repeated periodically according to severity, every 10 minutes in critical patients, every hour in stable, serious patients. Guys, we've reached the end of this super complete class on emergency approach. Recapping everything we saw, we understood the definitions and classifications of trauma, the importance of the team and structure, the severity-based triage system with categories from I to IV, and most importantly, the complete ABC protocol that saves lives. Airway with all the techniques for opening the airway, good breathing with adequate ventilation and oxygenation, and circulation with all the parameters we need to assess.
We also saw the ABORDAGEM acronym for Systematic Secondary Assessment, ensuring that no system is forgotten.
Always remember, in emergency, time is life. The Platinum Minute is real. Protocols save lives because they ensure you don't forget any essential step when under pressure. Prepare your teams, organize your emergency rooms, train the protocols, and you will see the difference in the results. I really hope you enjoyed this class. Any questions? I'm at your disposal. A big hug and see you next time.